This is one of a series of 8 films featuring some of the early pioneers of quality improvement in the NHS, who share their personal stories and the practical wisdom gained from leading improvement when it was still a niche activity. The idea for the films was originally conceived during a conversation between Peter Wilcock and Helen Bevan about capturing the legacy of early improvement leaders, and it was given life by the publication of the National Framework for Action on Improvement and Leadership Development. I've been privileged to have met all of the leaders featured in this series of films early on in my own improvement career, and so I found it fascinating hearing their reflections as they look back on their experiences. We hope that their stories will make a powerful contribution not only to those of you implementing the new national framework, but to everyone aspiring to improve healthcare. So Angela, you were Chief Executive of the Royal Death and Exeter for 20 years. Mm-hmm. What was the defining moment that got you involved in improvement work?
So when I was appointed at the RDNE, I was the 5th Chief Executive in 4 years, and I'd been in post probably less than 3 months when somebody said, "Can I have a conversation with you about a problem?" And that became what was known as the East Devon Breast Screening Service, where we had to rescreen about 1,000 women. We had a number of missed cancers. And what became clear from that was staff had worked really hard, but they'd worked around the system because they knew there was a problem. And the organisation's response to data that was beginning to indicate there was a problem was to investigate, to justify the data, and to say we're on average okay, therefore we don't have a problem. And what became very clear from that was if you don't look at the variation between individual practice, you can mask opportunities to improve things for patients, and therefore that variation was the problem that we had. In aggregate it looked just about okay, but when you looked at the individual practitioner and outcomes for patients, it was masking quite a significant problem.
And what was some of the key learning for you from that early experience?
So the key learning I think really was about you have to pick up the stones and keep asking the question. It's very tempting, it's very easy to justify why these things are normal. There's a normal distribution, that we're better than average on a number of things, rather than really questioning from a patient perspective, what's the opportunity to improve? From a practitioner perspective, what's the opportunity to improve?
So fast forward to 2001, and you got involved in a new national initiative called Pursuing Perfection, along with other chief executives from the North and East Devon area.
So the big thing with Pursuing Perfection was it was working with patients, working with staff, working with data in a very different way, and really teasing out and unpicking what the data was telling you in terms of variation, and then using PDSA cycles to do that rapid cycle of change, because we were very much before that time in an audit culture that if you couldn't audit or research something and take 6-12 months and then repeat the cycle, you didn't change anything because you need to do that, and that was much too slow for many of the things that we needed to do. But also staff need to be empowered to change things now, and if it works for one patient, then you do it for 2 patients, you do it for OBE, you do it for a ward. So that rapid cycle, that rapid tested change was quite invigorating in terms of staff had power to make the changes, to do the things that they knew were right. And importantly, we had data to support that and to analyse that so you can see the impact of your actions, which allowed you to do 2 things. One was to know whether the change you made was working, or whether indeed the change that you all thought was going to be the right thing made no difference whatsoever. So being able to endorse or eliminate, to myth bust on some of the things that everybody thought would work, was just a really important concept.
So you mentioned the difference with Pursuing Perfection in its real focus on what was important to patients. Can you tell us a bit more about that?
So it encouraged you to think very much about having the patient in the room, and when you're talking about service design or improvement, really exploring from a patient perspective what's important to them, because you'll have a load of professionals with their views about what's important, but that dialogue with the patient in terms of what outcomes they want to see is really, really important. And at that stage, this was before patient stories or those sorts of things becoming the norm. So it introduced you to a different perception, a different insight into what was important and what should be driving your improvement work. And then that drove us as leaders to think in terms of, so if our organisations reinforce silos, how do you lead a system? How do you work with your colleagues? And how do you cede authority to one of your colleagues if they're leading a programme or a piece of work or facilitating staff across multiple organisations to make changes? You have to cede authority. You can't say to your staff, you can go along, but you must come back and check every decision with me or somebody else. You have to move to a point where you cede authority. And I suppose the point for me where I knew that was working, but I had to take a deep breath and continue to role model it was the right things, when one of the CCG chief executives was leading on the delayed discharge project that we were doing. And she authorised the closure of the discharge lounge in my hospital, and I didn't know she'd done it until after it had happened. And it was fine because nobody really noticed. It was the right thing to do. But you had to take that deep breath and think, your initial reaction was going to be, so why didn't somebody think to tell me that was about to happen? But challenging yourself in terms of, so no, that's, if you're ceding the authority, if you're saying staff, you make change because it's the right thing to do from a patient perspective, then your behaviour and the leadership job you have is to support and endorse that. So all of us have to think very differently about how we behave and how we work. And it's fairly obvious with hindsight, but at the time, it was the totem, if you want, for actually how we were really working in a very different way.
So what were some of the experiences and learning that really stood out for you during your time with Pursuing Perfection?
That the staff really do know how to redesign and improve services, and the leadership role is to liberate those ideas. So it's very much more moving to facilitation rather than project management. You need project management, but actually facilitation and creating the environment and the space for people to do really great things for patients is the leadership task that you have. So one example that really brought it home to me was in our radiology department, where we had particular problems with patients that came to the department on beds. Where you stored the beds whilst the patient was getting their treatment limited the number of patients you could get through. So the team got together to discuss the problem that they were seeking to solve. For some, the starting point was you just built a bigger waiting area for these beds to be put in. And there was a porter sitting next to a radiologist who said, "Can I ask a question?" And the question was, why do patients need to come to the department in beds? And there was a sort of stunned silence around the room. And the answer was, for some patients, they need to be on a bed. But for the vast majority of patients, they don't need to be on a bed. Some can walk, and some can be brought down by wheelchair. And this chap went on to say, so if that's the case, we can double the number of people we bring down to the department. And that simple change changed how that department worked, the number of patients they could get through, the dignity of the patients not being stuck, hanging around in sort of just a waiting area. Transformation isn't a great big idea that you just implement and you transform a service. Transformation comes from very small changes for large numbers of people. And that's a transformation that you can deliver quite easily. It's not some grand idea that you've designed in the boardroom or with a group of chief execs, it's facilitating staff to work in a different way and really challenging yourself every time you look at changing process. For whose benefit are you changing process? The other approach that the Institute of Health Improvement focused on was storytelling, and actually hearing the patient's voice through that. And what that began to create for me as a leader and for working with staff is being able to tell that compelling story, but ground it in, this is what it means for Mrs. Smith. And that's the great thing about pursuing perfection. You manage the patient story, the storytelling element in terms of why is it important with what the data told you. You have to collaborate, and collaboration is the only way to successfully deliver great care at scale and at pace. And that whilst you'll have personal accountabilities, you have to view those and deliver those accountabilities in the context of the wider system. To say my bit's great and the rest is poor is a bit like saying I'm glad the hole in the boat isn't at my end. And there are always going to be tensions there, but fundamentally the only chance of succeeding is if you work in a collaborative way. And that's not reducing things to the lowest common denominator. That's having some of the really hard, gritty conversations about what is right. And if it was your mum or your son, what would you expect to happen and what behaviours would you wish to see from those organisations that were serving you?
And how are you applying that learning with your new role?
So same sort of principles, and I suppose to an extent you think, well, 20 years on, have we really made progress if we're having these conversations? But I think the really important thing to remember with any improvement journey is you never reach a point when you say you've done it. And we start these conversations around sustainability and transformation plans and collaboration from a different starting point to the starting point that we had 20 years ago. And in 20 years' time, there will be a different starting point because it's the same process, really, the PDSA process that you follow for any improvement methodology. There are always ways to improve.
And so how did you actually embed that culture of improvement within the Trust?
We asked the staff and we asked the members, what are the top 5 things you'd like us to focus on? And control of infection came out as one of the top 5. And then you began to look at, so how do we translate that area that people are concerned about into part of our improvement journey, part of our strategy? And at the time, the NHS was great at giving organisations targets for the number of MRSA bacteremias you could have in 1 year. The aim, rightly, was to reduce the overall numbers. But when you explored that, if our target was 10, it was our organisation and the wider health system saying it was okay for 10 people to suffer the devastating impacts of an MRSA bacteremia. And if you were one of the 10 people, you wouldn't think that was a great improvement target for you. So the challenge we translated that into was one of the strategic objectives should be that we would eliminate all avoidable hospital-acquired infections. And if none of us want to be one of the 10 patients for whom it's okay to have an MRSA bacteremia that's been caused by our processes within the hospital, then that's the thing that we need to tackle. And we are now at the point when I left, we'd gone 6 years without having an MRSA bacteremia. And that requires every part of the hospital, whether it's the cleaning staff, the nursing staff, the medical staff, to come together and systematically deliver the bundle of care that we know from the evidence base eliminates avoidable bacteremias.
What were some of your biggest challenges in doing this work, and how did you overcome those?
So I think it's keeping it fresh. And Pursuing Perfection was a programme we were on for 2 years, and the big risk with Pursuing Perfection when the funding ended was we do what we quite often do with pilots and projects. It's, oh well, that was very interesting, and now we move on to the next topic. And the challenge, I think, in leadership terms, it's very tempting to say, oh, we're going to do something completely new now. It's that meshing together the building blocks that you've built up over a number of years, and then asking the question, what's going to take you to the next level? And that's, you work with your system partners and you work with, in your own organisation, to say, this is incremental, this builds on. We may, as a consequence of that, decide that some parts of some of the techniques we were using no longer give us the added value, because actually we've set a new level that we're starting from. And they almost become part of business as usual in terms of how you do work here. But moving into working with local authorities in a different way, understanding and working alongside the voluntary sector in a different way, requires you to open your mind to what other approaches are out there, so that you don't have to, you can't go in and say to a new partner, we've got this history of working in this way for the last 10, 15 years, and all you need to do is adopt what we've done, and then both of our lives will be so much better. Because actually that's going back into the old style of, I can describe perfectly how my system would be much better if you changed.
So Angela, as a busy chief executive, how have you found and maintained your motivation and personal resilience to really do this improvement work?
So I love my job, I always have, and I work with some great people, predominantly at the RD&E, but elsewhere, and so part of that work has to be improving outcomes for patients, improving the way staff and patients feel about their care. So the buzz you get from seeing staff that are happy, empowered, really compassionate about the care that they offer, they're the things that light you up when you have those really dark, difficult days. And so I work with a coach. I've worked with a coach for a number of years, and you have to have the ability to say, it doesn't feel great today, and to be open in terms of when things have gone wrong, how that makes you feel, because you're human alongside everybody else, and we can all put the professional face on to front the really difficult conversations. But the resilience you build is the knowledge that with your staff, with the teams that you have developed and lead, patients get a great deal from the NHS and from the service that you have. And that getting out and about and having the confidence to spend time with staff doing their normal work pays dividends. I think the staff like it, the patients like it, and it builds your resilience when you're in those really difficult conversations that you don't really want to have, because it binds you to the people and populations that you're serving.
We know that developing a culture of continuous improvement and learning has to become core business for the NHS. You've described a huge amount of experience from your own journey in doing just that in Devon. So what advice would you give to today's leaders of improvement?
Be clear about your role within leading the organisation, setting standards, but work with your patients, work with the patient groups that you've got, work with your staff groups that you've got, because all of the ideas will be generated by those people. And your task, your role, is to orchestrate those ideas with the tools and techniques that you know that are available, with the bedding in of data, reducing variation, and together that gives you the toolkit that you need to make any change that's necessary. But you've got to work in a way where you want the outcome for every single patient to be at a level that you'd want for your own family, your own friends, because then you keep that personalised element of why is this important, and that's incredibly compelling and powerful for staff. So if it's not good enough for you, it's not good enough for your family, then it's not good enough for the patients that are currently going through your institution, your system. And that's the standard you should hold your health to.